اسمه ايباد، يا ريت كله يقفل المايكات.
السلام عليكم ورحمة الله. كل سنة وانتم طيبين وموفقين بإذن الله في الامتحان، وربنا يعينكم جميعا ويكتب لكم التوفيق. أنا هحاول أعمل زي مراجعة سريعة على الأشعة. الأشعة طبعا زي ما انتم عارفين حاجة بحر شديد التلاطم. على كل إن إحنا بس نرجو من الزملاء اللي عنده عيال صغيرين يحاول يعني يتخلص منهم على جنب شوية لحد لما نخلص الموضوع. وفي نفس الوقت بنحاول نسجل الكلام دوت علشان الناس تستفيد منه بعد كده. طيب
تمام يا فندم.
نتكلم على طول بقى إن شاء الله. طيب هو بس من مصلحة الجميع إن ما يكونش فيه زيطة في التسجيل علشان يطلع كويس والناس كلها تستفيد منه. الحاجة التانية إن أنا I will comment على ال cases by English so that many of the non-Arabic students can get benefit of this presentation. We'll start by the first case, and there are some of the cases I will provide choices so that you can select one of these, and other cases I will not provide these choices and you have to predict the correct diagnosis. Then this is the first case of an X-ray and MRI of the finger showing an osteolytic lesion sharply defined in the distal part of the metacarpal, and the MRI showed a soft tissue component of the lesion, and these are the choices. What do you think? Gout. Any other possibilities?
Giant cell tumor?
Yes. Actually, you know that gout, this is not the correct site for the gouty lesions. They should be more close to the joint line, and they are usually associated by a soft tissue component. But if you look in the MRI, you'll see that the soft tissue component of the lesion is intimately related to the tendon sheath, and this is one of the classic appearances of giant cell tumor of the tendon sheath. This giant cell tumor of the tendon sheath is considered the second most common soft tissue mass in the hand and wrist. Then whenever you see this lesion, one of the good possibilities to suspect the giant cell tumor, which is nothing but a localized form of pigmented velonodular synovitis. And the differential diagnosis will include a ganglion cyst, a cyst which will contain fluid, pigmented velonodular synovitis, which is the major type of this giant cell tumor, but they affect the large joints, desmoid tumor, and fibroma. Whenever you use the gradient images, they will not show evidence of hemosiderin inside the fibroma. This is the second case.
Right upper lobe collapse.
Right upper lobe collapse. Other possibilities?
It's a golden sign, right upper lobe collapse due to central mass.
Yes, and this is right. This is a central type of bronchogenic carcinoma that has occluded the upper lobe bronchus associated with collapse of the upper lobe and the classic S sign of Golden. And if you look carefully here, and you see that the superior vena cava is obliterated, and this is an indication of mediastinal invasion and a contraindication for surgery. Then these are the radiographic signs of bronchogenic carcinoma. If you are asked in the exam about a patient who has a bronchogenic carcinoma in his chest, what are the possibilities that you can see in the plain film? Number one, you can see a peripheral nodule with a speculated margin. You can see enlarged dense hilar shadow. You see a mass of whatever edge, smooth or speculated. And you see a central lesion with diaphragmatic elevation due to phrenic nerve paralysis. You see consolidation due to bronchial obstruction, the malignant pleural effusion, and the S sign of Golden. And this is the S sign of Golden, which is formed by the tumor mass and the edge of the collapsed lobe. You see the margin of the collapsed lobe and the edge of the tumor, which is should be a central tumor, and this is what we call the S sign of Golden. The next case is for a 76 years old patient with an incidental finding. And this is the chest X-ray and the CT scan, and here are the possibilities.
Anterior mediastinal mass.
Anterior
Yes,
mediastinal mass.
yes, this is right. This is not a fat because of the CT, is not a cyst because of the CT, is not a consolidation because no air bronchogram, and the remaining is an anterior mediastinal mass. What do you think of this mass?
Lymphoma versus thymoma.
Okay, very good. And we have four possibilities in the anterior mediastinal mass: the thyroid, the thymus, the teratodermoid, and the terrible lymph nodes, which is an indication of lymphoma. So we have four T's for the anterior mediastinal mass. This is, of course, is not a thyroid mass and is not a teratodermoid because of the absence of fat and calcium. The remaining two possibilities are the thymic tumor and the lymphoma, and this tumor has proved by biopsy to be a thymic tumor. Then thymoma is one of the anterior mediastinal masses that can be suspected by the plain film by the presence of a mass that has a good contact with the mediastinum. Actually, in the plain film of this particular case, you should suspect also the bronchogenic carcinoma because of the elevation of the diaphragm. And you know that thymoma can show extensive calcification as you see in this particular case. Then the next case is for a female patient, 65 years old, with left-sided chronic renal troubles.
Tensogranulomatous
Granulomatous
Yes,
sinusitis.
this is right. And this is densogranulomatous pyelonephritis, which is a non-functioning kidney that is partially replaced by fat in some cases, and there is a big stone. This is one variant of the chronic pyelonephritis. It's seen mainly in patients, in diabetic patients because of the immune compromise. The disease is usually unilateral, but it can be bilateral, and the treatment is by nephrectomy. The next case,
Appendicitis?
Appendicitis with appendiculus.
yes, appendiculis, very good, and there is a significant swelling of the appendix with edematous wall and the appendiculis causing posterior acoustic shadowing. The appendicitis occurs whenever the appendix is obstructed, and these are the causes: lymphoid hyperplasia, appendiculis, foreign bodies, Crohn's disease, stricture, tumor, parasite, and so on. The obstruction will lead to increased intraluminal pressure with venous engorgement and arterial compromise. This will result in tissue ischemia, infarction, and maybe perforation. These are two types of appendicitis: without appendiculis and with appendiculis. And you see the acoustic shadowing of the appendiculis and the edematous wall of the appendix in both conditions by ultrasound. The next case.
Epidural hematoma.
Yes, and this is epidural hematoma with classic appearance because of the crossing across the midline and the displacement of the enhancing dura and this coronal T1 weighted image after contrast injection. You know that the epidural hematoma is an extraaxial collection of blood. It has a convex inner margin. It can cross the midline but cannot cross the fissure, and it is almost always acute. The next case. Abscess. You said abscess?
GBM.
Okay. And you see here, this is the flare image, and this is the T2, and this is the flare image, and here is the diffusion, the ADC map, and this is post contrast. Then you got a lesion that is surrounded by significant perifocal brain edema, and also exerts some mass effect with enhancement of the wall and enhancement of the adjacent soft tissue. It's a good prediction that this is an abscess. It was proved to be a tuberculoma. And the tuberculoma or tuberculous abscess or correlate to each other, but you see the diffusion restriction in the lumen or in the central part of the abscess, which is not the case for the tumors like metastasis or glioma. Then the next case is a male patient, 35 years old, HIV positive, loss of weight, bleeding per rectum, distended abdomen.
Bilateral adrenal hemorrhage.
Lymphoma.
Bilateral adrenal masses as well as
Masses.
renal masses as well as pelvic mass, and all these
Lymphoma.
masses. Yes, you are right. In the presence of this history, which is HIV positive, you know, the possibility of lymphoma should be highly suspected. And this is Burkitt lymphoma, which involves too many organs. And the age of Burkitt usually in the young patients with male to female ratio 4:1, and it affects many organs, as I have said, and the prognosis is usually good. And this is an example of Burkitt lymphoma in a female child with right-sided lower abdominal mass, and you got a big soft tissue mass involving a good part of the abdomen as well as in the pelvis. It has been proved to be a Burkitt lymphoma. The next case is a female patient, 87 years old, with breast cancer, and she has been subjected to a motor car accident with brief loss of consciousness. These are the possibilities for this sclerotic lesion in the vertebra: lymphoma, metastasis, Paget, renal histodystrophy.
Metastasis. Paget.
Okay,
Paget.
and the difference between Paget and metastasis is the size of the vertebra. If you see that the vertebral size is big compared to the upper or the lower vertebra, then you should consider the possibility of Paget, since a metastasis do not cause enlargement of the vertebra. In spite of the patient had positive history of primary malignancy. Then Paget is one of the bone diseases that is still of unknown etiology, and there are three stages: the lytic phase, the mixed phase, and the sclerotic phase. The most common appearance of Paget is sclerosis in the vertebral body, together with enlargement of the affected bone, whether this bone is the hemipelvis or the femur or the vertebral body, as you can see here. And you remember that the differential diagnosis of solitary dense vertebra are three: metastasis, Paget disease, and
lymphoma.
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 Yes, good. The next case is you see here is T1, T2, and then the flare, gradient image, diffusion, ADC, contrast enhancement. What do you think?
Infarction.
Bilateral thalamic infarction. Infarctions do not usually enhance.
Infiltrating glioma.
Necrotic
Glioma do not show
encephalitis.
diffusion restriction.
Metabolic
Meningoencephalitis.
Yes,
intoxication.
and this is meningoencephalitis because of number one, the diffusion restriction. Number two, the pattern of enhancement, and this is what we call enhancement along the Virchow-Robbins spaces and the perivascular spaces. And this is one of the characteristic findings for a patient with meningoencephalitis. The next case is a spine, sagittal T1 and sagittal T2. What do you think of these lesions in the anterior part of the vertebral bodies? Is
Romanus lesion.
sorry?
Romanus.
Yes, Romanus lesions. Yes, Romanus lesions, you know that they are some sort of enthesitis that is commonly seen in patients with ankylosing spondylitis. And these lesions may be active if they show bone marrow edema, which should be low signal in the T1 and high signal in the T2. But they are inactive if they show fatty changes, like these lesions showing fatty changes, then these are multiple Romanus lesions. What is the pathology of Romanus lesion? There is just an inflammation of the anterior corner of the vertebra. Then this inflammation will lead to erosion, and the erosion will lead to some deposition of bone, leading to the formation of syndesmophytes, which will be followed by fusion and ankylosis. Then these are the possibility, the pathogenesis of the Romanus lesions, where you got some inflammation, then erosion, then syndesmophytes, then ossification, and the final stage of bamboo spine. Then if you look here and you see the lesion is of low signal in the T1, high signal in the T2, and this is active Romanus lesion. But if you look here and you see a lesion that is bright in the T1 and dark in the T2, and this is inactive Romanus lesion. The next case.
Renal replacement lipomatosis.
Yes, very good. This is a replacement lipomatosis of the kidney, which usually follows the chronic infection disease in the kidney, especially the xanthogranulomatous pyelonephritis. All what remains from the kidney is some necrotic tissue, and the whole renal tissue is replaced by fat, and you can see also the stone. The pathogenesis of replacement lipomatosis starts by obstruction of the kidney by staghorn stone, which will lead to stasis followed by chronic pyelonephritis, and it may go into the xanthogranulomatous type, and finally it will end by almost total replacement of the kidney by fat, leaving only the stone as you can see here. Then replacement lipomatosis is replacement of the kidney by fat. It is associated with long-standing infection and calculi, especially in patients with xanthogranulomatous pyelonephritis. All you can see here is fat at the site of the kidney and the stone, and you can hardly see renal tissue. Then what are the differential diagnosis of replacement lipomatosis of the kidney? Number one is renal liposarcoma, which is an extremely rare pathology, and there is no stone in the tumor. Angiomyolipoma is a hypervascular lesion. Lipoma do not contain soft tissues. Xanthogranulomatous pyelonephritis has a good overlap with replacement lipomatosis of the kidney. The next case is a child with this brain scans, and you see T1 and the flare, the diffusion, the coronal T2, I think this is ADC, and this is the post contrast.
Astrocytoma.
Medulloblastoma will show diffusion restriction. Astrocytoma
Astrocytoma.
is a good possibility because of the cystic component in the lesion, and actually the tumor is compressing the fourth ventricle, is not occupying the fourth ventricle. The second case, the next case.
Parosteal osteosarcoma.
Very good. And this is parosteal osteosarcoma, classic appearance, classic location. And the parosteal osteosarcoma is a variant of osteosarcoma commonly located in the popliteal fossa along the back of the lower end of the femur. And this may be mistaken for myositis ossificans, even with the pathology, with histology. But myositis ossificans occurs in front of the femur, which is a common site for trauma, while the parosteal osteosarcoma occurs on the back of the femur, which is a typical location almost in about 60% of the cases. There is what is known as the string sign, which represents the cleft between the tumor mass and the cortex of the femur. This is also seen in cases of myositis ossificans, but because of the classic site of the lesion, you should suspect parosteal osteosarcoma, and this is the another case with the MRI T1 weighted image of the same patient. Then the next case is MRI of the rest T1 weighted images. Then what do you think?
Rheumatoid arthritis.
Very good. And this is rheumatoid arthritis. And you can see the erosive changes in the carpal bones as well as in the distal part of the ulna, which is a classic site for rheumatoid arthritis. And nowadays, the rheumatologists consider MRI as a first line for investigation of patients with rheumatoid arthritis because of the development of new drugs that can give good results if you discover the disease early and you treat the disease early. And this is also common in patients with this axial spondylo arthritis. And I will present a lecture about this very soon, inshallah. Then this is a case of a neck CT where the patient has fever and neck pain.
Retropharyngeal abscess.
Yes, and this is retropharyngeal or prevertebral abscess. This is good. If it is in the tonsil, it will be located somewhat laterally. And this abscess is in a dangerous location because of its close relation to the carotid vessels and also the close relation to the airway. Then in the plain film, we used to diagnose prevertebral abscess by enlargement of the prevertebral soft tissue compared to the diameter, anteroposterior diameter of the cervical vertebra. From C2 to C4, the prevertebral soft tissue shadow should not exceed 1/3 of the vertebral body width. But from C4 downwards, it is almost equal to the AB diameter of the vertebra. Then if you see enlargement like this, you may suspect a retropharyngeal tumor and others, but if you see ehrlichioli, then you should suspect an abscess. And this is an important notification. The serious position of this abscess is due to its close relationship to the carotid vessels and internal jugular vein. And the abscess may affect the artery and cause hemorrhage. They may lead to weakness of the wall, causing pseudoaneurysm, and may lead to vascular thrombosis. Also, downward extension of the abscess may go into mediastinum, which is a serious complication also. In the next case is
Uterine adhesion.
okay,
Asherman disease.
Asherman disease or intrauterine adhesions. Good. The next case,
Dural emphysema.
Epidural hematuria. Subdural emphysema.
this is not a subdural lesion, it is an epidural pathology.
Meningioma.
Calcified meningioma.
Calcified meningioma, and you should see calcium in the T2 more better than in the T1 weighted image.
Meningioma with cystic changes.
This is not
Lymphoma.
cystic in the
Dural
CT.
lymphoma. Lymphoma.
Yes, and the remaining possibility is lymphoma, and this is dural lymphoma, of course. And whenever you see a lesion like this, which is not fitting well with blood and not fitting well with infection and not fitting well with meningioma, think of the two other possibilities, which are lymphoma and metastasis. These are the commonly suspected possibilities for a dural lesion like this. Of course, if you can include also sarcoid, but sarcoid will show a more or less homogeneous enhancement. Okay?
Diffuse axonal injury.
Yes, and this is diffuse axonal injury, which is a classic lesion with a classic history. There should be a motor vehicle accident. There should be a major type of head trauma, and the patient is near totally disturbed. Whenever you are asked about your opinion in a patient who had suspected for a motor vehicle accident and is deteriorated, his conscience is deteriorated, but the CT scan is normal, you should think immediately of diffuse axonal injury. And axonal injury means rupture of the axons of the nerve cells, which is due to a shear injury between the cortex and the white matter. This is a serious injury, but it may lead to subtle changes in the CT and MRI in the form of a few petechial hemorrhages. If you see this in a patient with major head trauma, you should suspect a diffuse axonal injury. Then
Multilocular cystic nephroma.
good. This is multilocular cystic nephroma, which is Bosniak type 3 renal cyst, or you may classify it as an individual pathology. You see the claw sign indicating that this is of renal origin. You see multiple internal septations. It has two beaks in the children, in the pediatric age and in the adult age, and sometimes it may show internal calcification. And this is the appearance of the gross appearance of the lesion, the appearance by ultrasound, without contrast and with contrast. Next case.
Langerhans cell histiocytosis.
Yes, and this is Langerhans histiocytosis because of the variable sizes of the cysts, the predominant affection of the upper and the middle lung zones, the thickness of the cyst itself, the presence of minute pulmonary nodules. These are quite different from lymphangioliomyomatosis, which is a disease of females in the productive age, and the cysts are almost of similar size, and they affect even the costophrenic angle, and the wall is very thin and there are no nodules. These are the difference between the two. Histiocytosis occurs when there is infiltration or proliferation of the histiocytes in the lung, and this will result in small nodules. When the nodules are large, they will cavitate and form cystic changes. And finally, these cystic changes will cause total damage of the lung. Sometimes the rupture of one of the cysts may lead to pneumothorax. And this disease has intimate relation to smoking. And the chest physician cannot or refuse diagnosis of histiocytosis without history of smoking because of the intimate relation between both. The disease affects the upper and middle lobes, especially not the lower lobes, in distinction to the lymphangioliomyomatosis. If the disease has progressed, it will destroy the lung parenchyma and it will end by fibrous tissue. And then if you want to treat the patient, first of all, he should stop smoking. Then you may use corticosteroids. But in spite of the management, some of the patients will develop progressive damage of the lung, ending by respiratory failure. And what do you think?
Sturge-Weber syndrome.
Yes, Sturge-Weber, and this is a classic appearance by MRI. You got the cortical leptomeningeal vascular malformation with ipsilateral enlargement of the choroid plexus. Many times you cannot see the calcium by MRI, but these findings are quite enough to diagnose Sturge-Weber syndrome. Next case.
Sarcoidosis.
Yes, and this is sarcoid. You got bilateral symmetrical enlargement of the hilar shadows, and this is one of the classic appearances of sarcoid. Actually, you have 5 stages of sarcoid. Stage 0 is the normal chest radiograph. Stage 1, mediastinal lymphadenopathy. Stage 2, lymph nodes and reticular opacities in the lung. Stage 3, reticular opacities without nodes. Stage 4, complete destruction of the lung with pulmonary fibrosis. This is an example of a stage 1. You see enlargement of the hilar shadows. And this is an example of stage 2, enlargement of the hilar shadows with reticular opacities in the lung. And this is stage 3. You got reticular opacities, but you cannot see the lymph nodes because the nodes are very small and they are also calcified. And these are the changes in the lung window. You hardly see the lymph nodes by CT, but you cannot see them by X-ray. The final stage is similar exactly to pulmonary fibrosis with honeycombing, traction bronchiectasis, and so on. Next case.
CA prostate.
Left or
Benign prostatic hypertrophy. BPH.
CA
prostate.
prostate left.
What pathology?
BPH.
Two pathology.
Two pathology. What?
Peripheral lobe.
Yes. The first one,
Prostate hyperplasia and CA.
T2.
yes, and this is benign prostatic hyperplasia, and this very small lesion in the peripheral zone on the left side represents a prostatic cancer. Yes.
Vestibular schwannoma.
No.
Meningioma.
Meningioma.
No.
Cholesteryl granuloma.
Bilateral
Schwannoma neurofibromatosis type 2.
Yes, this is the right answer. And you see this very small schwannoma in the internal uterine canal and a big one on the left side, on the right side. And this is neurofibromatosis type 2 because of the bilaterality of the lesion. You should not miss this lesion, particularly in cases of acoustic neuroma. Next case.
كيف سبب الأدرينال
Myelolipoma.
Adrenal myelolipoma, and a fat-containing lesion in the adrenal gland is a classic appearance for adrenal myelolipoma, which is a rare benign tumor. Usually it is non-functioning lesion of the adrenal gland and may be complicated by hemorrhage in some conditions. About 10% of these adrenal myelolipoma can be associated with some function, especially in cases of Cushing or congenital adrenal hyperplasia or Con syndrome. The treatment of a choice depends on the size and the appearance of the lesion on imaging. If there is a small lesion with classic appearance, no treatment. If an intermediate appearance or indeterminate appearance, you got biopsy. If the lesion is large and hemorrhagic, it should be excised. Next case.
Retroperitoneal liposarcoma.
Okay, other possibilities.
Bilateral myeloma.
Bilateral sclerosis.
Very good. This
Sclerosis.
is bilateral angiomyolipoma. This is part of the right kidney that has been pushed across the midline. You see the kidney and a big mass of fat arising from the kidney, and there is another fat-containing mass arising from the left kidney, and this is bilateral angiomyolipoma. You know, the incidence of bilaterality is high in patients with tuberous sclerosis.
renal cell carcinoma cystic type.
Very good. And this is cystic renal cell carcinoma because of this nodule. If you miss this nodule, you will say a Bosniak type 1 simple renal cyst, but the case is not simple renal cyst, it is a cystic renal cell carcinoma. This is an ultrasound of both testes, and you got two masses.
Lymphoma.
Yes, very good. Lymphoma because of the age of the patient, and you know seminoma occurs in younger age than this. But if you see if you see two or bilateral testicular masses in an old age, think of one of two, either lymphoma or metastasis.
Hepatoblastoma.
As the child is too old for hepatoblastoma. Hepatoblastoma, the age should be below
HCC.
Hepatocellular carcinoma.
yes, HCC occurring at a younger age is known as fibrolamellar type of HCC. The fibrolamellar type of hepatocellular carcinoma is different from hepatocellular carcinoma in many ways. There are 7 characters for fibrolamellar hepatocellular carcinoma. Number 1, it occurs at a relatively younger age from 15 to 40. It has no association with cirrhosis. It is usually larger at presentation, more than 12 centimeter in size, and is not associated with changes in the alpha fetoprotein. And it is less aggressive with better survival rate. and it has a central scar, and so they usually differentiate it from the focal nodular hyperplasia, and it may have delayed enhancing capsule similar to the HCC. And what do you think?
Lymphoma.
Lymphoma or
GBM.
GBM.
or
Dermatocytic MS.
there are three lesions, and you should remember the lesions are the primary lesion of the site you are dealing with, then lymphoma and metastasis. They are always joined together. Then if you see a lesion like this and you think of lymphoma, and lymphoma is a good possibility, but there are central areas of necrosis inside the lesion. Then you think of glioblastoma multiforme and metastasis if there is a history of primary malignancy. These are the three very good possibilities, okay?
Intraventricular meningioma.
Carcinoma.
Carcinoma?
Choroid plexus carcinoma.
No. This is
Meningioma?
meningioma, as she has said. This is meningioma, intraventricular meningioma, homogeneous enhancement, and you got some lobulation of the outline because of the big size of the tumor. This is the most common trigonal mass in intraventricular trigonal mass in adults. Then, if you see a lesion in the trigone, the choroid plexus papilloma usually occur in the pediatric age group. 85 of the cases are below the age of 5 years. Then this is the intraventricular meningioma is the commonest trigonal enhancing mass in adults, and it represents about 2% of all intracranial meningiomas, and usually it shows a smooth margin, and it enhances homogeneously, and it may contain calcium, of course. The differential diagnosis is between the choroid plexus, but the patients are young, as I have said. The low-grade glioma like ependymoma, oligodendroglioma, astrocytoma, and also they occur in a relatively younger age than a meningioma. The meningioma and metastases occur in adult age.
Budd-Chiari syndrome.
Yes,
Budd-Chiari.
very good. Budd-Chiari syndrome, and you got this enlargement of the liver with heterogeneous enhancement, and you got marked attenuation of the IVC, and also you cannot see the hepatic veins. There is ascites and some enlargement of the spleen. And this is also another example. You got heterogeneous enhancement of the liver, especially the periphery of the liver, which is relatively hypoperfused compared to the central part of the liver. The IVC is attenuated, and you cannot see the hepatic veins. The Budd-Chiari is due to venous obstruction after, as they said, post-hepatic venous obstruction of the hepatic veins and the IVC. This will result in backflow into the portal vein and may result in stasis and thrombosis. There are many causes, of course, and idiopathic is the most common cause, but carcinomas and other tumors, also blood dyscrasia, sickle cell anemia, polycythemia vera, and so many causes can result in this syndrome.
Spondylodiscitis.
Spondylodiscitis, very good. And the main issue here is the involvement of the disc. If the disc is involved, forget about trauma, forget about metastatic deposits, and you should think of infection. And you know that the main issue for diagnosis of infection is involvement of the disc as well as the adjacent end plates, whether it is associated with abscess formation or not. Then if you got affection of the disc with bone marrow edema of the vertebrae and erosion of the vertebral end plates, this is diagnostic of spondylodiscitis.
Calcaneal lipoma.
Very good. And this is lipoma, intraosseous lipoma, because this is not a fluid density, so that you may think of a cyst in the calcaneus. It is more hypodense than fluid. Then you consider fat, and the intraosseous lipoma is one of the good possibilities.
Spinal
Spinal edema.
Phylum.
arteriovenous fistula.
Yes, and this is actually, these cases are, I don't know why they are frequently seen in the clinical practice, for me at least. And you got a very classic history of a patient with progressive lower limb weakness and the sensory loss ending by uncontrolled micturition and defecation. Then most of the patients are thought to have disc lesion, and many of these patients have been already operated for disc lesion and they did not improve. The clue here is the detection of these minute vessels in the subdural space, and these are not artifacts. You see the artifacts like this. The artifacts are hazy and bulky, but these are a signal void and they are tortuous, as you can see here. Then this vascular malformation or arteriovenous fistula will result in shunting of the blood from the arterial side to the venous side. Then the cord will suffer from ischemic changes, starting by edema, followed by infarction. And the best treatment way is to select the artery feeding this vascular malformation and embolize this vascular malformation. Actually, if it is large, it may also involve the cord substance itself, and you got intramedullary vascular malformation together with dural arteriovenous fistula.
Aneurysmal bone cyst.
Aneurysmal bone cyst, yes, this is aneurysmal bone cyst, and you got the classic appearance of a finger in a balloon, meaning that you go to while you are approaching the lesion, suddenly there is marked expansion, and this is in contra distinction to the simple bone cyst. And simple bone cyst is a longitudinal lesion without abrupt change in the caliber between the lesion and the normal bone. And this aneurysmal bone cyst have been treated by sclerotherapy with good results, as you can see here. One of the major criteria of aneurysmal bone cyst is the presence of multiple fluid levels, although these fluid levels can occur in other lesions, but they are very, very pathognomonic for the aneurysmal bone cyst. And you know that aneurysmal bone cyst also occurs in the spine, affecting the neural elements and can extend into the vertebral body.
Parathyroid adenoma.
Yes, and this is parathyroid adenoma, and this axial stair is the best pulse sequence by far to detect the parathyroid adenoma, because the adenoma will show bright signal compared to all the surroundings. The adenoma is usually in the size of 8 to 15 millimeter, and many times they said that there is no need for imaging since the clinical picture is classic. But nowadays the imaging is essential, especially in recurrent cases, in unilateral surgical exploration, in suspecting ectopic adenoma, which may occur in the mediastinum, detection of other lesions in the thyroid gland itself, and decrease the surgical complications. This is the appearance of the parathyroid adenoma by ultrasound and by Doppler, and you see the vascularity. This needs very high resolution ultrasound and also an expert radiologist to spot this appearance. Next case.
Variant dermoid.
Bilateral dermoid.
Yes,
Bilateral
It
dermosis.
is bilateral, and the dermoid cyst bilaterality is well known. And you got the classic appearance of fat, soft tissue component, and calcium. And this lesion occurs in more than 70% of the cases in younger age group, and it is bilateral in about 10% of the cases. And you got the three classic components: fluid, fat, and calcium.
Giant cell tumor.
Sarcoma.
Is not osteolytic in the X-ray.
Ossifying fibrosis.
Sorry? You see the age of the patient?
Osteosarcoma.
The age of the patient is old for osteosarcoma. Then, as I have mentioned in the lectures, if you see a lesion and you cannot know its nature because of the absence of criteria and age, and you have to decide, is this lesion
Chondrosarcoma.
benign or malignant?
Chondros.
Is
It's
this
malignant.
malignant? Okay. Then if you decide that this is a malignant lesion, what do you consider? You consider metastasis, you consider lymphoma, and you consider other primary bone tumors that occur in old age, like fibrosarcoma, its name is
Fibrous osteosarcoma.
yes, fibrous, malignant, fibrous, histiocytoma, and leiomyosarcoma, and so on. Then, if you know that this patient had breast cancer in the history, then the possibility of metastasis should be considered. But if the history is not clear, as usually occurs in the exam, then you say that this is a malignant lesion, and the diagnostic possibilities are so and so and so.
Congenital
Liver
liver
emphysema.
No.
or foreign body inhalation.
Yes, this is foreign body inhalation.
Foreign body.
This is hyperinflation. There is no collapse of the lower lobe and no crossing of the emphysematous lung or the hyperinflated lung across the mediastinum. And these are essential features to diagnose congenital lobar emphysema. But if you see the difference between inspiratory and expiratory film and the whole lung is affected, you should think of a foreign body inhalation. The pediatric physician said that the foreign body inhalation does not occur before 1 year age group, but you have seen actually, and I have seen many cases that are younger than 1 year of age. Then the most classic clinical presentation is wheezes, and usually they go by endoscope to remove the foreign body. When they need the imaging, whenever they failed to detect the foreign body by the endoscope. But nowadays, they usually have the imaging first, then they go by the endoscope to pick up the foreign body. And if you are asked what are the radiographic findings of inhaled foreign body, first of all, you have to say that normal chest X-ray is seen in about 1/3 of the cases. Then you may got hyperexpansion, atelectasis, air trapping, and so on. What do you think?
Abscess.
Yes, and this is the classic appearance of an abscess with air fluid. Sometimes you got around the abscess some inflammation of the adjacent lung parenchyma, and you should look carefully for the air fluid level to realize that it is straight nor wavy, so that you can differentiate between abscess and ruptured dilated cyst. Abscess is either acute or chronic. The acute abscess contains air fluid level. The chronic abscess contains only air, and in both conditions, the inner wall of the abscess is smooth. And this is quite different from a breaking down in a neoplasm, which will show irregularity of the inner margin, like this case. And this is the abscess, and this is cavitating bronchogenic carcinoma.
Mediastinal teratoma.
Yes, and this is mediastinal teratoma because of the fat. Actually, there are three criteria for teratoma: fat, calcium, and the fluid. And two criteria are enough, but one of these two should be fat. Then if you see fat with fluid is enough for the diagnosis of teratoma. You cannot usually reach the diagnosis from the plain film in many cases, but the CT scan will show the presence of calcium, fat, and other soft tissue components. This is diagnostic of teratoma. And this is another example. You see a big mass, and you cannot swear that this is teratoma, but you may say that this is a mediastinal lesion because of the good contact of the lesion to the mediastinal border. Then by the CT scan, you see calcium, fat, and the fluid, and this is teratoma. In this case, if you feel that this is a child, you should diagnose this big mass as a neuroblastoma. But if you have the CT scan and you can see locules of fat and calcium as well as soft tissues and the fluid, you should diagnose teratoma.
Mafushi.
Yes, and this is Mafushi syndrome, which is a disorder affecting bones and the skin, and it will result in multiple enchondromas as well as soft tissue hemangiomas.
Metastasis, lymphoma.
Lymphoma metastasis. Other possibilities?
Abscesses.
No.
Sarcoidosis.
Sarcoidosis.
Okay, if you say that these are metastases, where is the primary malignancy?
Right renal.
Right?
Adrenocortical.
Where is the left kidney? Is removed, and the left kidney is removed, and this is the source of metastasis. And you got the this is one of the tricks in the exam. You know that if a patient had mastectomy and the breast shadow is absent, and this is the clue for the diagnosis in chest problems. And also here, if you look and you do not see the kidney, and you see evidences of malignancies, then you suspect that this kidney was the source of malignancy. But if you do not know the history and the kidney is present, you may consider that this kidney is the source of metastasis. If not, all of these lesions can represent lymphoma because of the involvement of the spleen. And you know, spleen can be involved by metastasis, but commonly it is involved by lymphoma.
Rectal malignancy.
Rectal carcinoma.
Stage
Stage 2.
Three.
Yes.
That's true.
Yeah,
Three.
stage 3, because of the invasion of the muscularis and the invasion of the adjacent fat and the presence of perirectal lymph nodes. Lymph nodes is not included in the staging, but stage 1 and 2 respect the muscularis propria. Stage 3 invades the muscularis and may reach the perirectal fat.
Neurofibromatosis.
Very good. And this is neurofibromatosis because of multiple lesions showing the classic target sign and the T2 weighted images with the central low signal and the peripheral high signal. Very good.
Endometriosis involving rectum.
Very good. Yes, and this is endometriosis classic appearance of the serrated margin in the anterior wall of the rectum, because the endometriosis may go from the uterus and infiltrate the adjacent anterior wall of the rectum. This is a very classic appearance, but endometriosis of the bladder will affect actually its posterior wall.
Typhlitis.
Yes, very good. This is typhlitis or neutropenic enterocolitis, and you got some mucosal edematous changes and inflammation of the pericolic fat, and you need actually some history to support your diagnosis because this may be overlapped by a cecal carcinoma. And this patient had fever, right side abdominal pain. She had appendectomy and is on chemotherapy for leukemia. Then the patient should be immune compromised, and the blood cell count should be very, very low, and many cases may have also aplastic anemia or maybe HIV positive like this. Then this is the difference between typhlitis and carcinoma. Carcinoma is will appear in the form of a mass, sometimes with stranding of the fat, sometimes no. But this you feel that the mucosa is edematous and there is no actual mass. And this is another example. You know that barium enema and colonoscopy are contraindicated, and the best examination is the CT. You got cecal distension and the mural thickening, the stranding of the surrounding fat. You may got paralytic ileus in the rest of the small bowel, pneumatosis and pneumoperitoneum, and you may also got some fluid collections around the affected area.
Esophageal carcinoma.
esophageal lymphoma.
Yes, lymphoma is very good possibility because carcinoma will surround the lumen circumferentially, while lymphoma will do like this in an eccentric location, and the lymphoma goes in the submucosal space, and this is fits well for submucosal extension of the tumor. And also lymphoma involves a long segment of the esophagus, and this is clear here from the root of the neck up to the carinal level. But sometimes you cannot differentiate between lymphoma and carcinoma. If you see that the lesion is circumferentially surrounding the lumen, and you cannot decide if it is submucosal or not, and you should select the carcinoma because it is more common than lymphoma in this particular situation.
Osteosarcoma.
Osteosarcoma.
Yes, and this is a classic appearance of osteogenic sarcoma with Codman triangle, sun ray speculation, and soft tissue mass. Okay.
Plexiform gangliosarcoma.
What do you say?
Glioblastoma. Plexiform gangliosarcoma. Central neurocytoma.
Pleomorphic, you mean?
Cystic
Pleomorphic
meningioma.
gangliosarcoma is a
Yes,
cystic
yes.
lesion with a peripherally located enhancing mural nodule. But this lesion has a cystic component and a solid component, and this was a glioblastoma multiforme. Then in this case, you see a marginally enhancing lesion in the right temporal lobe, and the diffusion of this lesion shows diffusion free. What do you think?
Brain abscess.
GBM.
Yes,
Anaplastic astrocytoma.
diffusion free
GBM.
means that this lesion is not an abscess, but it is a glioblastoma multiforme, which is frequent in the differential diagnosis.
Lymphangioma. Mesenteric lymphangioma.
Multi-abscess.
No?
Multiple hydatid cysts.
Very good. Yes, and these are multiple hydatid cysts. They are not abscesses because of the absence of significant enhancement. And this is not, of course, the intestine with obstruction. And this is not lymphangioma because lymphangioma, the internal septations are very thin and they communicate with each other. These are peritoneal hydatidosis.
Plexiform neurofibroma.
Yes, and this is plexiform neurofibroma. This is not hygroma, it is solid. And this is not rhabdomyosarcoma, it respects all the facial planes around. And this is not parotid lymphoma because the parotid gland is not shown here and is not involved by the lesion. This is plexiform neurofibroma.
lymph node.
Yes? Diagnosis?
Lymphoma.
Yes, bulky, homogeneously enhanced lymph nodes is diagnostic of lymphoma, whether it is Hodgkin type or the non-Hodgkin type. Lymphoma by ultrasound also showed the same criteria: bulky appearance, homogeneous texture, and vascularity on Doppler examination. The only type of lymphoma which may show some internal areas of breakdown, but the nodes are still bulky, is known as the nodular sclerosing type.
Congenital vertebral fusion.
Between
2, 3, 4, 5.
this vertebrae,
4 and
2, 3,
yes.
4, 5. You know, if there is congenital fusion, the disc is almost obliterated and the vertebrae are elongated and reduced in the anteroposterior diameter.
Yes.
Vertebra.
Gibbous deformity.
Gibbous deformity due to
What's disease?
yes,
Joint
this is
dislocation.
osteomyelitis
There
or
is abscess. There is abscess.
spondylodiscitis, and you got widening of the perivertebral soft tissue and the erosive changes of the upper part of C5 vertebra together with the lower end plate of C4 as well, and this is infection. Infection is diagnosed by the involvement of the disc. This is very important. And the erosive changes of the vertebra sometimes associated with prevertebral or retrovertebral inflammatory granulation tissue.
Inflammatory neuroblastoma.
Neuroblastoma.
Yes, and this is neuroblastoma or olfactory neuroblastoma. Actually, if you see a mass in this particular location, the diagnosis is 4 lesions. Number 1, ethmoidal carcinoma with intracranial extension. Number 2, skull base lymphoma. Number 3, metastasis. And number 4 is the olfactory neuroblastoma. In the olfactory neuroblastoma, we are sure about the diagnosis if you see cystic lesions along the margin of the lesion intracranially. But if not, all the possibilities can be included. And these are the differential diagnosis: is xenoneuroblastoma or squamous cell carcinoma, lymphoma, metastasis. And also, if the patient is young, you may include skull-base rhabdomyosarcoma. This lesion is a highly malignant tumor, affects the region of the skull base, the anterior skull base, and it has an intracranial component and extracranial component. And frequently you can see these cysts around the intracranial component. Yes.
Full thickness supraspinatus tear.
Full thickness tear.
Full thickness tear of the supraspinatus tendon because of osteoarthritis of the acromioclavicular joint and type 3 acromion with anterior hook. And all what you need from the full thickness tear is to measure the gap of the tear, and you say the state of the muscle, if it is atrophic or not.
PCO, polycystic ovary.
Yes, and this is a classic appearance of polycystic ovaries. You got some ovarian enlargement, but very important, the sclerotic stroma, which is of black signal and the T2 weighted image, and also the sclerotic capsule of the ovary. And you see that the polycystic ovary contains follicles of almost the same size. There is no dominant follicle as seen usually in the normal ovary. Then it is an easy diagnosis, as you know, and these are the imaging findings. About 10 follicles in the size of 2 to 8 millimeter, thickened sclerotic capsule and central sclerotic stroma, as you can see here.
Congenital pulmonary airway malformation.
Diaphragmatic hernia.
Yes, this is adenomatoid malformation or congenital pulmonary airway malformation. This is the new name, but if you look carefully here and you see this is a barium study, and this barium study, the barium does not go through the intrathoracic lesion, meaning that it is not a diaphragmatic hernia, but a congenital adenomatoid malformation of the lung. And this is a hamartomatous proliferation of the terminal bronchioles, resulting in significant enlargement of the lung, containing so many cystic changes, first filled by fluid, then filled by air. And these changes may affect the whole lung, or may affect a lobe or part of a lobe. The enlargement of the lung will cause shift of the mediastinum, compression of the opposite lung. And there are 3 types of cystic adenomatoid malformation: type 1 with big cysts, type 2 with medium-sized cysts, and the type 3 with microscopic cysts, and this cannot be diagnosed in the clinical practice. The first one is the most common.
Hydatid cyst.
Yes, and this is 2 hydatid cysts, one intact and one ruptured. This is the ruptured hydatid cyst with what you call meniscus sign, or air in the wall. And you know that this is also hydatid cyst because of the classic finding in this right one. Then these are the X-ray finding of pulmonary hydatid disease. Either you got the sharply well-defined pulmonary nodule or mass, then you got pulmonary mass with air in the wall, which is known as the halo sign, or cavitary lesion with the wavy air fluid level, or the water lily sign, or cavitary lesion with a mass inside similar to the fungal ball, or multiple masses and cavities containing air fluid level. And these are the signs of hydatid anywhere in the body. Either a simple cyst without any diagnostic criteria, or you got air in the wall of the cyst, which is known as the meniscus sign, or you got floating shadows on the surface of the fluid, which is known as the water lily sign, or you got these floating shadows within the cyst fluid, which is known as the serpent sign, and other signs which are not common in the clinical practice. This is what we call the compo sign, or the floating shadows on the surface of the fluid. And this is the serpent sign, where you got collapse of the endocyst, forming what looks like a mass inside the cavity.
Transitional septum.
Sorry?
carcinoma or
renal cell carcinoma.
Transitional cell carcinoma of the right kidney.
Transitional cell carcinoma or urothelial carcinoma, the new name. And you see a mass in the renal pelvis, and the renal pelvis is distended, and this is diagnostic of transitional cell carcinoma. You know that many of the lesions that can present as a mass in the renal pelvis, but the most common and on top of all these lesions is the urothelial carcinoma. You may got radiolucent foreign bodies, blood clots, polyps, hypertrophied papilla, vascular impression, inflammatory conditions, but the urothelial carcinoma is on top of all these lesions.
Spinal lymphoma.
Yes,
Small bowel lymphoma
yes, and
or adenocarcinoma.
actually, you know that lymphoma is a long segment, and this is a long segment. A lymphoma occurs distally, and this is distally. And many times you got some overlap between lymphoma and adenocarcinoma. But if you say that this is lymphoma, good. If you say that this is adenocarcinoma, good. If you are asked about the third possibility and it is metastatic deposit. Then small bowel lymphoma is one of the well-known diseases, and it may be associated with HIV infection, celiac disease, organ transplant, or H. pylori bacteria. Lymphoma do not cause obstruction nor perforation, but it may cause hemorrhage and malabsorption. And lymphoma is a long segment, and sometimes it reaches 20 centimeter in length. It may also be associated with aneurysmal dilatation of the bowel in some cases.
Pilocytic astrocytoma.
Pilocytic astrocytoma.
Yes, and this is pilocytic astrocytoma, the most common cyst with an enhancing mural nodule in the posterior fossa of a child. And I have mentioned many exceptions for the cyst in the posterior fossa representing pilocytic astrocytoma. These exceptions include enhancement of the cyst wall, diffusion of contrast inside the cyst forming contrast fluid level, internal hemorrhage within the cyst, variable size of the nodule, calcification of the cyst wall. All these findings are acceptable in cases of pilocytic astrocytoma.
Portal venous malformation.
Portal venous malformation. Its actual name is
Cavernous transformation of the portal vein.
Yes, very good. This is portal cavernoma or cavernous transformation of the portal vein. The portal vein is not usually seen and is replaced by a collection of vessels in the region of the porta hepatis, and this may indent the wall of the common bile duct, resulting in such appearance, and may result in ectasia of the bile. This is usually the case of complicating portal vein thrombosis, but according to the literature, the portal vein needs not to be thrombosed for the cavernoma to form. Then this is multiple venous channels around a previously stenosed or occluded portal vein. The venous channels are portoportal collaterals. They are derived from the biliary and gastric branches, and they compose this cavernoma. This is a cervical MRI, axial T1, and the patient has a neck pain, severe neck pain.
Dissection.
Cervical metastasis.
Yes, and you got a low signal bone marrow infiltrating lesion involving in most of the body of the cervical vertebra and is encasing the vertebral artery in the new foramen transversarum. Then this lesion is for the differential diagnosis, of course. Metastases are on top of this appearance, and also lymphoma may have a similar appearance. Sometimes the plasmacytoma may cause this appearance as well. Then you may think of this was metastasis from breast cancer in this particular case.
Hydatid cyst.
Yes, very good. This is an intramuscular hydatid cyst, a very, very classic appearance. And you got a big cyst with internal daughter cysts. This is the T1, and this is the stair image. This is the spinal deposits. As you can see, the deposits are very well appreciated in the T1 weighted image without contrast, but less appreciated in the T2 and less appreciated after injection of contrast. And this will confirm my statement. I always say that the best way for detection of spinal deposits is the T1 without the need for contrast injection.
Pigmented villonodular ganglion cyst.
Man,
Meniscal cyst.
man, this is
Meniscal
not
cyst.
a pigmented villonodular synovitis because
Yes,
this
it is hyperintensity to
it
start.
is a fluid.
Sorry, yeah.
Then, if you see a lesion like this, if it is connected to the meniscus, it will be a parameniscal cyst. If not, it will be a ganglion cyst, and this is a ganglion cyst in the anterior compartment of the knee.
Carotid body tumor.
No.
Glomus vagale.
This is a glomus tumor, but it's not carotid body because it displaces both the internal carotid.
Vagal.
Yes, and this is glomus vagale. Glomus vagale will displace both internal and external carotid arteries anteriorly. There are 4 more common glomus tumors in the neck: the glomus jugular, tympanicum, vagale, and carotid body. But you should remember that the glomus tumor occurs in many other sites that are somewhat rare compared to these 4 sites. And the glomus tumor is usually benign, but it may have malignant characters in some percentage of the cases and may give metastatic deposits.
Endometrioma, T2 shading.
Yes, endometrioma T2 shading. You see in the T1 weighted image a bright lesion, and in the T2 weighted image the signal drop due to the mixture of blood, acute and subacute blood. And this is diagnostic of endometrioma. Endometrioma means ectopic endometrium, and these are the locations. Ovaries, the most common, broad ligament, anterior cul-de-sac, posterior uterosacral ligament, uterus, adenomyomatosis, and fallopian tubes, colon, and ureter. Then one of the best diagnostic criteria is the T2 shading, meaning drop of the signal in the T2 weighted image due to the mixture of blood, as I have mentioned.
Lysencephaly.
Lysencephaly, yes, and this is a classic appearance of lysencephalic brain with a smooth surface apart from minimal small gyri. And lysencephaly is one of the rare malformations of the cortex, and all the cortical malformations present by epilepsy. Then you got a very smooth surface of the brain, very short vertically oriented sylvian fissures, thickening of the cerebral cortex, and absence of the gyri. Thank you very much, and I hope إن شاء الله ربنا يوفقكم في الامتحان بإذن الله تعالى، ونلقاكم دايما على خير.